Good afternoon or good evening wherever you are. Welcome to the APGS second masterclass. I'm Dr. Seng Kiong Fang from Kuala Lumpur, Malaysia, the current president-elect of APGS. Today, masterclass will be by Professor Clement Tham, and he will be talking to us on management of primary angle closure disease. Before we go to the masterclass, I would like to Introduce a bit on Asia Pacific Glaucoma Society. Can I have the next slide? Yeah, these are the APGS member benefits. Mainly, you get a registration discount for the Asia Pacific Glaucoma Congress. And you have access to the online education platform, which are recordings of the APGS webinar series and surgical videos. You have a quarterly newsletter, online communities where you can discuss various topics such as MIGS, tubes, medical management, and you have free online access to the Journal of Glaucoma, and the rest of the benefits are listed down here. You can scan the QR code to become a member and join APGS. Next slide, please. Yeah, this is just to showcase our various sessions that we have been conducted. APGS webinar with American Glaucoma Society, European Glaucoma Society, International Society of Glaucoma Surgery. Next, please. Okay, today's speaker is Professor Clement Tham, and he is the chairman and SHO professor of ophthalmology and visual sciences at the Chinese University of Hong Kong and director of Chinese University of Hong Kong Eye Center. And he has been our vice president of APGS since 2014. And he was chair of the scientific program committee of the inaugural APGC in Bali. And he is also Congress President and Chair of Organizing Committee of the second APGC in 2014 in Hong Kong. He has a long, illustrious career. He's a member of Board of Governors of the WGA, Chair of the Organizing Committee of the World Glaucoma Congress in 2005 in Hong Kong. And he's current Secretary General and CEO of the APAO, which is the largest supranational ophthalmic organization. Next slide, please. And he is also the treasurer of the ICO and appointed to the chair of the scientific program committee of the WOC in 2016 and also Barcelona WOC in 2018. And you can see here, he has got a long list of awards that is given to him. Next slide, please. So today is my great honor to present Professor Clement Tham, who will be talking to us on management of primary angle closure disease. Can we have his video, please?
Ladies and gentlemen, I'm Clement Tham from the Chinese University of Hong Kong. Welcome to this Asia Pacific Glaucoma Society Masterclass entitled Management of Primary Angle Closure Disease. These are my financial disclosures and also the government funding that has gone into supporting our work on PACG research. Now, in the management of primary angle closure disease, there are three important steps. In the first step, we try to open up all appositionally closed portions of the angle as far as we can. If the intraocular pressure is still uncontrolled, then we start topical medications. And if IOP is still not controlled by maximally tolerated medications, then we consider proceeding to further surgery. There are at least three ways we can use to open up appositionally closed portions of the angle, and these include laser peripheral iridotomy, argon laser peripheral iridoplasty, ALPI, to open up residual appositionally closed segments of the angle after iridotomy, and also finally lens extraction. Now, the word primary in primary angle closure disease can be misleading because this word usually implies that there are no unknown underlying causes or mechanisms leading to the disease. But in primary angle closure disease, actually, there are at least several known mechanisms, and these include pupil block, plateau iris syndrome, lens-related mechanism, and also possibly choroidal pressures. And the lens-related mechanism may include the anterior-posterior position of the lens, the thickness of the lens, as well as acute lens swelling. Now, this figure here tries to conceptualize the mechanisms leading to angle closure in different eyes. So the x-axis, we've got 4 separate eyes here, and the height of this column represents the anatomical predisposition to angle closure. You can see that the different colors represent the different mechanisms leading to angle closure. And say, for example, for eye number 3 here, plateau iris is the main contributing mechanism causing angle closure, whereas in eye number 4, the lens thickness is the main mechanism leading to angle closure. And the higher is this column, the greater is the risk of progression along the spectrum of angle closure disease. Now, in this second figure here, it looks very similar, but this time it is actually the same eye, but going through different ages. That means at different age, at different time points. You can see that with increasing age, there's increasing predisposition to angle closure. And this is very largely because of the increase in lens thickness. And with an increase in lens thickness, there's also possibly an increase in pupillary block component. So the risk of angle closure increases with age and with time. Now, in the next 2 slides, I'll try to summarize a management algorithm for primary angle closure disease based on the type of angle closure. Now, in this very first slide, it is a hypothetical situation in which 360 degrees of the angle is completely appositionally closed, with ocular hypertension with or without glaucomatous optic neuropathy. In this situation, if you are able to deepen the anterior chamber and widen the drainage angle, chances are that the trabecular measure can be once again accessible to aqueous drainage. So you may not need to do anything further after you have opened up the drainage angle. Now, in this situation, if there is visually significant cataract, then you may consider cataract extraction. If there is still persistent appositional angle closure with plateau iris syndrome after the cataract extraction, you may consider argon laser peripheral iridoplasty. On the other hand, if there is no visually significant cataract, you may start with laser peripheral iridotomy to eliminate any pupillary block. If there is persistent appositional angle closure with ocular hypertension after iridotomy, then you have to decide whether plateau iris syndrome or the lens being the main mechanism leading to angle closure, and you have to treat accordingly. Now, in this second slide here, this is another hypothetical situation in which 360 degrees of the drainage angle is completely semiquely closed. So this is the other end of the clinical spectrum. Once again, there's ocular hypertension with or without glaucomatous optic neuropathy. So in this scenario, if there is visually significant cataract, then you proceed to cataract extraction. But just by opening up, by widening the drainage angle, the peripheral anterior synechiae may still be blocking aqueous drainage. So very likely, you may need another intraocular pressure lowering procedure combined with the cataract extraction in order to bypass the blocked filtration site. And in this situation, you may consider goniosyneciolysis, various forms of cyclophotocoagulation. You may consider combining the cataract extraction with mix where appropriate, combining with trabeculectomy, or perhaps even with glaucoma drainage device implantation. In this scenario, if there is no visually significant cataract, then you would have to decide whether the lens is the predominating mechanism leading to angle closure. If it is, you may consider lens extraction, once again with or without another IOP lowering surgery. If the lens is not the main contributing mechanism, then you may proceed with one of these IOP lowering surgery with or without lens extraction. Now, based on this algorithm, very often we would have to decide whether plateau iris or the lens being the main mechanism leading to angle closure. And how do we decide? Now, there are at least two important pieces of evidence supporting plateau iris syndrome. And these include seeing the double hump sign during darkroom gonioscopy and also seeing the characteristic plateau iris anatomical configuration during ultrasound biomicroscopy. Now, in this darkroom gonioscopic view of this particular drainage angle, you can see that there is no trabecular meshwork structures visible, so the drainage angle is closed, and this is after laser peripheral iridotomy. The next step, you would need to do a darkroom indentation gonioscopy in order to distinguish between synechial or appositional angle closure. Now, with indentation, you can see that now the trabecular meshwork is revealed with the angle opened, and so this is a case of appositional angle closure. And the other very important feature you can see here is what we would call the double hump sign. You can see that the iris is raised up over here. There's a small hill over here, and then it dips down into a valley, and then it once again rises up over another small hill before it dips into the drainage angle. So it is in the form of a double hump. And the reason for this double hump is because more centrally, the iris is being draped over a very prominent and anteriorly positioned lens. And then it drapes over the periphery of the lens. And finally, it rises up again over a very anteriorly positioned and prominent ciliary body. So this is characteristic of plateau iris syndrome. Now, in the UBM images, in the upper image here, you can see a very prominent and anteriorly positioned ciliary body, which is pushing the peripheral iris towards the drainage angle, towards the inner surface of the cornea. And in the upper UBM image here, the eye is actually in a lighted room with the pupil in a relatively constricted stage. And so you can see that the angle is still open, even though narrowly. But in the bottom figure, this is now in a dark adapted state with the pupil relatively dilated, and the iris is now bunched up towards the drainage angle, which closes off the drainage angle. Now, with plateau iris syndrome, argon laser peripheral iridoplasty is a useful technique. This technique involves the placement of contraction laser burns onto the peripheral of the iris. And the typical laser parameters used would include a very large spot size of about 500 to 1,000 microns, a relatively longer duration of about 0.5 seconds. And usually for brown iris, we start from a very low power of 150 to 250 milliwatts and titrate according to what we see at the iris. For lighter iris, we may use a smaller spot size of 200 microns, and also we may need to start with a higher power of 200 to 300 milliwatts. Now, sometimes in some texts, it is described to use a much smaller spot size, shorter duration, as well as much higher power for these iridoplasty laser burns. Please do not use these, because with such laser settings, especially in brown iris, you cause these small charred burning of the iris without good iris stromal contraction. Furthermore, in this particular photo here, the laser spots is also being applied too centrally, too far away from the peripheral part of the iris. And so in this particular situation, the iridoplasty is very unlikely to work. Now, while you apply the laser peripheral iridoplasty, if there is no iris stromal contraction visible, then you increase the laser power. Alternatively, if you see bubble formation, iris charring, or pigment release into the anterior chamber, or if you hear a pop sound, then you decrease the laser power. Normally, we apply about 20 to 24 laser spots over 360 degrees of the iris. We avoid large visible radial blood vessels as far as we can. And also do not place the laser spots too closely to each other, because otherwise there's an increased risk of iris necrosis and atrophy. Now, this is a video demonstrating the placement of iris contraction burns in the far periphery of the iris. You can see that as soon as the laser spot is applied, there is contraction of the iris towards the laser application site. There's also thinning of the iris stroma at that point, and also deepening of the anterior chamber at that particular position. And this serves to widen the drainage angle as well as mechanically pulls open the appositionally closed drainage angle. So this is a very good demonstration of an effective laser iridoplasty. Normally, this is performed under topical anesthesia, and my own personal preference is to use the Abraham contact lens. Now, this UBM image demonstrates that when the laser contraction burns is applied to the correct position, there's good iris stromal thinning, which leads to opening, widening of the drainage angle at this critical position, with subsequent opening of the drainage angle by an effective iridoplasty laser contraction. Now, by far, I think the most common reasons why iridoplasty sometimes do not work is because it is not applied peripherally enough. Now, on the left-hand side here, you can see that the laser, in this particular eye, the laser is very well placed in the far periphery of the iris, and there's good iris stromal contraction and thinning, and so the angle is reopened. But on the right-hand side here, the laser spot is being applied too centrally. So even with the iris stromal contraction, there's no opening of the drainage angle here. Now, apart from argon laser peripheral iridoplasty, in fact, endoscopic cyclophotocoagulation may also have a role in managing plateau iris syndrome. Now, this is a laser technique that involves the direct visualization of the ciliary processes with an endoscope in the anterior chamber. And when we applied laser burns to the ciliary epithelium, you can see a contraction of all these ciliary processes. And this is also effective. This has also been shown to be effective in opening up the appositionally closed angles from in eyes with a plateau iris syndrome. Now, what about the clinical evidence supporting lens mechanism as the main contributing factor towards angle closure? Of course, there are all these quantitative anterior segment anatomical parameters that you can measure with ultrasound biomicroscopy or anterior segment OCT. But up to today, these are still largely for research purposes. Whereas in the clinical setting, I think by far the most important evidence would be the evaluation of the central anterior chamber depth at the slit lamp. This is because the central anterior chamber depth is the combined outcome of both the anterior-posterior position of the lens as well as the lens thickness. So in an eye with a very shallow central anterior chamber, the lens is very likely to be a major contributing factor towards angle closure. And by removing the lens, we would significantly deepen the anterior chamber and widen the drainage angle in such an eye. And the other sign is actually what I would call the Mount Fujiyama sign. This is when you're looking from an angle towards the anterior segment of the eye. For example, when using a gonioscope, you can see that the configuration of the iris and as well as the pupil takes on the appearance of a volcano. You can see that this is particularly looking like a volcano when the pupil is in a more constricted state. And the reason for this is because the iris is being draped over a very anteriorly positioned as well as prominent anterior lens surface. Now, just now, when we were talking about the management algorithm, we mentioned that sometimes with lens extraction or cataract extraction alone, it is not sufficient, and we may need to combine it with other IOP lowering surgery. So what would be my personal choice for this other IOP lowering surgery? Before I move on to that, first of all, we know that lens extraction is often the first intervention of choice in primary angle closure disease, especially when visually significant cataract is present and also when the lens is considered a major contributing factor to angle closure and intraocular pressure reduction is required. But lens extraction alone may not be sufficient if there is very advanced glaucomatous optic neuropathy necessitating a very low target intraocular pressure, or when there is grossly uncontrolled intraocular pressure. Now, this figure here shows my own personal lens extraction treatment spectrum. Usually for eyes in which you don't need a large extent of IOP reduction, I may perform just phaco emulsification alone. If I need more IOP or drug reduction, then I consider combining it with phaco, combining phaco with endoscopic cyclophotocoagulation. Of course, this is my own personal choice, and there are other options that are available that we have touched on earlier on. And then finally, if I want more or less maximum IOP reduction, then I'll do combined phacotrabeculectomy. You can see that as we move from left to right in this treatment spectrum, there is increasing IOP reduction, but at the same time, there's also increasing invasiveness, increasing surgical risk, as well as increasing surgical time. Now, endoscopic cyclophotocoagulation involves the placement of diode laser burns of continuous wave energy at 810 nanometers during direct visualization of the ciliary processes. Now, this animation here shows you how this procedure is done. Usually when it is combined with cataract extraction after lens implantation, you can deepen the anterior chamber with viscoelastic. Then with the endoscope in the anterior chamber, you can directly visualize the ciliary processes, and then you can apply laser over the ciliary processes. As soon as the laser is applied, there is whitening of the ciliary epithelium and also contraction of the ciliary processes. And it is very important that we try to apply, to cover the complete epithelial surface with the laser marks. You can see that the whitening needs to cover the ciliary processes, all of the ciliary processes, as well as the valleys in between the ciliary processes. Now, this is a pilot randomized controlled trial that we have conducted in Hong Kong, comparing phaco emulsification alone versus combined phaco ECP in PACG eyes. The orange line here represents those eyes, the mean intraocular pressure of those eyes treated with phaco ECP over a course of 24 months after the initial surgery, while the blue line represents the mean intraocular pressure of those eyes treated by phaco emulsification alone. Now, in this second figure, now we are looking at the mean number of drugs required by these eyes. And once again, the orange line represents those eyes treated by phaco ECP, while the blue line represents those eyes treated by phaco emulsification alone. Now, this very similar graph is actually from another much earlier randomized control trial conducted by our group, comparing phaco emulsification alone versus combined phacotrabeculectomy in medically uncontrolled primary angle closure glaucoma eyes with coexisting cataract. And you can see that just by performing the phaco emulsification alone, there's a very good intraocular pressure reduction, which is maintained well over 24 months. With combined phacotrabeculectomy, there is additional IOP lowering, and this additional benefit is also well maintained over at least 24 months after surgery. And if you look at the drug requirements for these eyes, once again, with phaco emulsification alone, there is very good drug reduction, whereas with combined phacotrabeculectomy, there's additional reduction in drug requirements, which is also well maintained over at least 24 months after surgery. Now, in this table here, I'm trying to compare phaco emulsification versus combined phaco ECP and also phacotrabeculectomy in PACG eyes. First of all, I must acknowledge that this is not a scientific comparison because I'm now pooling the data from two completely separate and independent randomized controlled trials. But at least I think this table should give you a rough idea as to how these three procedures compare with each other. In terms of mean IOP reduction at 2 years after surgery, phacoemulsification reduces IOP by over 21%, phaco-ECP by over 27%, while combined phacotrabeculectomy reduced IOP very significantly by well over 40%. In terms of drug reduction, phacoemulsification reduces IOP by over 32%, phaco-ECP reduces IOP by over 48%, while phacotrabeculectomy reduces IOP by over 83%. But of course, with combined phacotrabeculectomy, it is a much more invasive and much more major surgery compared to the other two, and so it is associated with a greater risk of surgical complications, both intraoperatively and postoperatively. Whereas with phacoemulsification alone, there's a greater chance that additional filtration surgery would be required within 2 years after the first intervention, as compared to phaco-ECP or phacotrabeculectomy. So this table summarizes very well my own personal lens extraction treatment spectrum, progressing from phacoemulsification to phaco-ECP to combined phacotrabeculectomy with increasing intraocular pressure reduction, as well as increasing invasiveness, surgical risk, and time when we move from left to right. Now, in making our final surgical decision, there are at least two very important factors we have to consider. The very first question we have to ask is how much IOP and or drug reduction is required. Of course, to answer this question, we have to look at the preoperative IOP and the number of drugs the patient is on before surgery. The glaucoma stage as well as the target IOP has also to be taken into consideration. And of course, the patient's age and the rate of glaucomatous progression must be considered as well. The second question we have to answer is how much surgical risk the patient and the surgeon can accept. Of course, to answer this question, we have to look at the status of the operated eye as well as the fellow eye. For example, if this is the only eye of the patient may be reluctant to undergo interventions with higher risk of surgical complications. Furthermore, we have to look at the patient's visual requirement, which includes the patient's work as well as hobbies. I think at the end of the day, it is extremely important that we give sufficient seat time to our patients and to thoroughly discuss the pros, cons, and risk of these different procedures with our patients before arriving at a final surgical decision with our patient. If you would like to read more about primary angle closure glaucoma, we have this textbook entitled Primary Angle Closure Glaucoma, A Logical Approach in Management, which is edited by myself and co-authored by a constellation of very distinguished clinician scientists from our region working on this disease. It is published by Springer and is now available on the Springer online shop, as well as on Amazon.com and many major booksellers. Finally, let me bring your attention to the 5th Asia Pacific Glaucoma Congress, which will be held from the 4th to the 8th of June this year. But if you are interested in contents other than glaucoma, then please do mark your diary for the APAO 2021, which is the first ever completely virtual APAO Congress from the 5th to the 11th of September 2021. Thank you very much for your kind attention and time. And I very much look forward to discussing primary angle closure glaucoma with you in the next discussion session. Thank you once again.
Thank you, Professor Clement Tham, for sharing on the primary angle closure disease. If you have any questions for Professor Tham, you can type in the question and answer box, and we will take the questions and discuss when the questions comes in. Right now, both of us will be live online, and we will be discussing more on the details of angle closure. There is one question that just came in. Clement, any role of pilocarpine in PAC or PACG with the clear lens?
Right, so thank you very much, Tanush, for this very interesting question. I have to say, at least personally, I extremely rarely use pilocarpine on any long-term basis in order to open up drainage angle. But for the reason that, first of all, it may not be very effective. We are all aware that there can be paradoxical closure of the angle when we are using pilocarpine. And secondly, most patients do not like the effect of pilocarpine. And sometimes they get headache, and also the dimming of the vision with pilocarpine is also not very satisfactory. So personally, I extremely use pilocarpine on any long-term basis. But instead, I would consider laser peripheral iridotomy, or perhaps with or without iridoplasty, plus considering clear lens extraction in a selected number of cases with the aim of widening the drainage angle. Thanks very much for the question, Tanush.
Yeah. The second question is from Rosalie Reyes. Clement, where does MIGS fit in your treatment spectrum?
Now, I think the role of MIGS in terms of its efficacy in IOP control and also the invasiveness of the procedure, I think it ranks somewhat alongside ECP. But then with mix, personally, the mix that I've done most frequently is the iStent. But with iStent, you really would need to be able to have good access to a drainage angle. So probably it's applicable to those cases with merely a positional angle closure, with which you are able to greatly widen the drainage angle and can have a good view of the trabecular meshwork, which is exposed after lens extraction. Then you may consider a role for mix. But otherwise, I think in the sort of moderate IOP reduction amount, in those cases that require a moderate amount of IOP reduction, my own personal preference is more often combined phaco and ECP.
Maybe, Clement, if you do iStent, do you do goniosynovial lysis before that?
In theory, you can. But my own suspicion is that for those cases that have had PAS, especially those with PAS for a prolonged period of time, I'm really not sure how healthy the drainage system is more distally. So I'm really not sure how effective iStent will be in those cases for PAS, even if you manage to strip the PAS.
Okay. Yeah, Tanush also asked any role of micropulse laser instead of ECP combined with phaco, I suppose.
I think yes. I think each of them have their pros and cons. If I'm already doing clear lens, if I'm already doing cataract extraction, I already have access into the anterior chamber. The reason I prefer ECP is because I can have direct visualization of the ciliary processes. So I can create the least amount of collateral damage as compared to any transscleral form of procedures such as micropulse or even the more traditional diode laser cyclophotocoagulation. So there's much less collateral damage. I can do it under direct visualization. And also, the laser power required for ECP is much lower. Usually, I use a setting of about 150 milliwatts to 200 milliwatts as compared to the 2,000 plus milliwatts as used in the micropulse lasers. So personally, if I'm already in the AC, I prefer ECP. But of course, for those cases in which either you have done just phaco emulsification in your first setting, or when you're not needing to do any invasive surgery, then micropulse cyclophotocoagulation is, of course, one possible option.
Yeah, we have quite a number of questions coming in now. Sunny Ao asks, how about the visual field outcomes in your RCT for phaco with phaco ECP? Do you have visual field outcomes?
Now, that was not part of the study design, but we did look at the visual fields because all those patients had that visual field done. We did not see any major significant difference in visual field. But having said that, a follow-up of 2 years is probably not enough to see major differences in visual fields. And also furthermore, that study was powered to look at IOP reduction. And so we may or may not have sufficient power to compare visual field changes, especially over such a short duration.
Yeah, thanks. Dr. Lance Liu also asked if a patient is on a maximum tolerated therapy with Dimox, do you go for cataract surgery alone or with ECP or with phaco trap?
Now, of course, that also depends on the pressure. If the patient is dependent on oral Diamox in order to maintain a relatively safe pressure, then I'll be much more inclined towards doing phacotrabeculectomy. Because in this patient, you'll probably be needing a much larger extent of IOP reduction. And furthermore, the other things you have to consider is the patient's willingness to take surgical risk and also how advanced the glaucoma is. So you have to take into considering the whole picture to decide whether a phaco ECP or the phacotrabeculectomy will be more suitable for this patient. Of course, one very important parameter you have to look at is the preoperative IOP while the patient is on MTMT as well as the oral Diamox.
Yeah, this is also in relation to ECP. I'm going down further. You can see the question. If ECPs are not available to decrease the IOP more than the effect of phaco, do you go directly to combine a phaco trap? If there's the center do not have a ECP.
Yes, I think so. Because phacotrabeculectomy, well, in trained hands, I think it's a very effective procedure. And even though in my talk, I was saying that it is associated with a little bit more surgical complications, I think it is still very effective and safe. And it is probably one of the most powerful procedure in significantly reducing intraocular pressure and also eliminating the need for glaucoma drugs. In my own practice, when I do phacotrabeculectomy, normally I try to apply the sutures a little bit tighter than what is eventually required, and then use laser suturizers to lyse the sutures during the 1 to 2 week post-operative time window. I think that significantly decreases the risk of overdrainage, hypotony, etc., and also protects the conjunctival wound from leakage, at least in the initial phase of the post-operative period. Yes, I certainly think phacotrabeculectomy can be a good option in those patients that require significant IOP reduction.
And in relation to ECP as well, what happens to the zonule of zinc when you do ECP? Do you affect the zonules?
Now, so far in our experience, we have not encountered any cases with loosened zonules or subluxed or loose IOLs after phaco ECP. But of course, that is one consideration we have to be very, very careful about. In fact, during all phaco ECPs or any ECPs, I always try to apply as little energy as possible. So basically, I titrate the energy against what I see through the endoscope. And what I'm aiming for is just a slight whitening and slight contraction of the ciliary processes. And I think that to an extent can protect us from excessive zonular lysis. But so far, fortunately, we have not had any cases with zonular lysis and loosened intraocular lens after ECP.
Yeah, thanks. I suppose you answered this one as well. If you don't have ECP, we can still use the micropulse transscleral cyclophotocoagulation. The next question is, what is cut off for angle closure for ACD? Is anterior chamber depth to consider as a lens mechanism? Do you consider the anterior chamber depth?
Yes, I think so. But having said that, I don't think right now at this moment we have a very definite evidence-based figure with which we can say for certain whether how significant the lens is or not. I remember there was one paper from the Singaporean group, I think, on Mongolian patients in which they noticed a dramatic increase in angle closure when the anterior chamber depth is below a certain point. But having said that, other studies have not been able to duplicate that same finding. So basically, in my mind, I use the ACD in a more qualitative fashion. The shallower the anterior chamber depth is, the greater is the likelihood of the lens being an important contributing mechanism. And of course, we can never just look at one single parameter and make a decision on the surgical option. We have to take into consideration all the other clinical findings. And at the end of the day, I would always stress that we have to have a very good conversation with the patient, explaining the pros, cons, and risk of each surgical option, and then arrive at a decision with the patient.
Thanks, Clement. Is lens extraction helpful in plateau iris syndrome?
Yes, I think so. Of course, there have also been studies that looked at patients with plateau iris syndrome and lens extraction. And in some patients, the opening of the angle may not be very significant. But having said that, I think in the vast majority of patients, by merely taking the lens out, you significantly deepen the anterior chamber, you widen the drainage angle, and very often you manage to reopen those appositionally closed portions of the angle that are caused by plateau iris configuration. Having said that, I would stress the importance of re-evaluating the angle in angle closure cases after phacoemulsification. Okay, if you still see a positional angle closure there, if there is still any evidence of plateau iris syndrome causing a narrowing or even closure of the angle after lens extraction, then you may consider laser iridoplasty that can help with plateau iris syndrome. And also in some of these cases, perhaps if you perform combined phaco with ECP, the ECP itself will also shrink down the ciliary processes, which may also help with the opening of the angle, that is, those angle closures that are secondary to plateau iris syndrome.
Yeah, we do have a lot of questions coming in. I will just screen through some of the questions. In PACS, when would you recommend iridotomy? I suppose this one is in relation to the ZEP study.
Yes. If you remember the data from the ZEP study, basically, if you do not do iridotomy, I think it's something like 8 in 1,000 cases will progress to the next stage, progress to either acute closure or PAC. Whereas if you perform iridotomy, this is reduced down to something like 4 cases per every 1,000 patients. So in a way, laser peripheral iridotomy is effective in reducing the progression to the next stage in PACS eyes. But having said that, even in those cases that did not receive iridotomy, the chance of it progressing is so low that I think the conclusion from the ZEP study was that it is probably not worth performing laser peripheral iridotomy in all PACS eyes. But then I think at the end of the day, each patient can still be different. In selected patients, I think you may still consider performing laser peripheral iridotomy. Say, for example, in those patients in whom you see a very shallow anterior chamber or a very narrow angle. And also in those patients in whom you may not be able to have very regular follow-up to monitor the progress of the angle closure. And also in those patients who require regular pupil dilatation, for example, diabetic patients, in those patients, I'll be more inclined towards considering laser peripheral iridotomy. But based on the findings from the ZEP study, I don't think it is justified to perform laser peripheral iridotomy in all cases of PACS.
Yeah, thanks, Clement. When planning cataract surgery in patients with shallow anterior chamber, do you dilate patients intraoperatively with intracameral injection or preoperatively, or do you give mannitol before the surgery or during the surgery?
Yes, I routinely use preoperative dilating drops for these patients. Rarely, if the pupil is not large enough, I may consider giving intracameral dilating agents. I very rarely use mannitol, except in those cases in which there's high pressure, very shallow anterior chamber, and then sometimes I may use mannitol to shrink the vitreous gel. But otherwise, in the vast majority of cases, I managed to use only preoperative dilating eye drops.
And coming to acute angle closure, Nazrul is asking, how do you treat acute angle closure?
Thanks very much, Nazrul, for bringing this up, because I would very much like to talk about this, but I didn't have enough time in my talk to cover this part. So in my mind, or in the treatment of acute primary angle closure, I usually conceptualize it into two stages of treatment. In the first stage of treatment, we aim to reduce the intraocular pressure and also to relieve the severe symptoms as quickly as possible. And in the second stage of the treatment, we aim to prevent a recurrence of the acute primary angle closure and to prevent the progression to the chronic form of angle closure. For the first stage treatment, traditionally, we have been using topical drugs as well as intravenous or systemic drugs or oral drugs. But more recently, randomized controlled trials have demonstrated that argon laser peripheral iridoplasty is very effective in rapidly reducing the intraocular pressure in these patients. And so nowadays, my own personal preference would be to use laser peripheral iridoplasty as the first line of treatment for acute primary angle closure cases. Other options have also been described for this initial treatment, including things like paracentesis and corneal indentation. But to me, I feel that laser iridoplasty is non-invasive, it is very safe, and so it is my own personal first choice in these patients. As for the second line of treatment, traditionally, we have been using laser peripheral iridotomy to prevent a progression of the disease. But based on a study that we have conducted in Hong Kong, we demonstrated that if you are able to do lens extraction in these patients at an earlier stage, actually the chance of the patient progressing to the chronic form of the disease or having raised intraocular pressure about 1 to 2 years down the line is significantly less. So nowadays, my own personal preference is I lower the pressure at the very beginning of ALPI, and then afterwards, I'll do lens extraction at an early stage. Of course, the next question you may ask is, how early is early? To me, I think if you perform the earlier you perform the lens extraction, the less is the chance of peripheral anterior synechia forming in a closed angle in an inflamed eye. But of course, the earlier you perform the lens extraction, the greater will be the inflammation, both perioperatively and postoperatively. And also, the more sensitized is the patient to pain when you perform the lens extraction during a very early stage after acute primary angle closure. So nowadays, what I normally do is, once the pressure is controlled with ALPI, I give the patient topical steroid and try to reduce the inflammation. And as soon as the inflammation is sufficiently settled, then I progress to perform a lens extraction. And that is usually around 1 to 2 weeks after the initial attack. And I find that this approach can give greatest patient satisfaction in terms of visual improvement, and also it significantly reduced the risk of having high intraocular pressure later on, and also reduce the risk of progression to APAC, recurrence of the APAC, or a progression to the chronic form of angle closure.
Thanks, Clement, for excellent overview on acute angle closure. I think we have only time for one last question, which is anterior segment OCT imaging sufficient in angle assessment, especially in patients who cannot tolerate gonioscopy?
I think for I myself, I find gonioscopy most useful, but sometimes the patient can really not tolerate gonioscopy, I suppose OCT does have its value. In fact, it's a very valuable tool because it allows us to objectively quantify the anterior segment parameters. But the only problem is that up to today, we still do not have good scientific evidence as to how to use those quantified anterior segment anatomical parameters in making clinical decisions. In fact, right now in Hong Kong, we are conducting a trial in which we're looking at the outcomes after various forms of surgical interventions, and in particular cataract extraction, and try to see if the preoperative anterior X and S segment OCT parameters, quantitative parameters, are indicative of post-operative outcomes. And I'm hoping that eventually we'll be able to use these quantifiable parameters to direct us, to guide us in a surgical option for these patients. But right now, I think it is useful. It tells us how narrow the angle is, how shallow the anterior chamber is. And of course, you can also look at the lens port, etc. But we have yet to be able to make surgical decision based on good scientific evidence and the exact figures of these quantifiable anterior segment parameters.
Thanks, Clement, and thanks to the audience for so many questions. We can actually answer only some of them. If you want, you can email the questions, and maybe we can get Clement to answer some of the questions for you as well via email. Before I close, I would like to share the upcoming session from APGS. Can we have the slide? Is the slide on? Yeah, the upcoming session for the next APGS session will be a free webinar. Actually, this is sponsored by Santen, and this is on the medical treatment of glaucoma, and you can see here all the speakers, and it's moderated by Professor Catherine Yu. Can I have the next slide, please? Yes, do join us for our fully virtual 5th Asia Pacific Glaucoma Congress, which is from 4th to 8th of June 2021, which is this year. The registration is already open. Early bird deadline will be extended probably by another 2 weeks. Do scan the QR code and also visit our website to register. We do have a lot of speakers lined up, and this over the 5 days you can have a discussion on medical management, surgical management, and everything on that you need to know on glaucoma. I would like to play a teaser video for this APGC.